Cambridge, where in Trinity College, the clock has just struck the hour. You come from all across the world, and there are over 4,000 of you, so it's fantastic to have you joining us today. I suppose it's a silver lining of the current events that we can all come together through technology, and that really is great. I'm Professor Sally Davis. I'm the UK's first ever envoy on antimicrobial resistance, and it's my great pleasure to be moderating today's discussion. But let's start with our thanks to those who've made this possible: the Antimicrobial Resistance Fighter Coalition, the University of Minnesota Center for Infectious Disease Research and Policy, the American Society for Microbiology, the Wellcome Trust, and the Surveillance and Epidemiology of Drug Resistance in Infections Consortium. We've got an inspiring array of speakers today who are sharing their expertise and insights with us all. So I'm delighted to welcome Dr. Hanan Balkali, who's the Assistant Director General for AMR at the WHO, Professor Rogier Van Doorn, who's the Director at the Oxford University Clinical Research Unit in Vietnam, Dr. Michael Osterholm, who's Director at the Center for Infectious Disease Research and Policy in the Twin Cities, Minneapolis. And we are hoping that Dr. Ngengason, who's the Director of the African CDC, will be able to join us, though as yet he hasn't made it. But of course, in any discussion, the important participant is you, because what we're trying to do today, help me with it please, is a dialogue. So your thoughts, questions, and insights are going to be terribly important to all of us. If you want to contribute, use the chat box. Please do use the chat box. Then we can have conversation flowing. And after we've had the interventions, the specific ones from our panel, we're going to open it up to answer your questions. So please fire away. I have to say that all the organizations who are supporting this have done a great job in arranging today's discussion. And our speakers are going to explore where we are, a hypothetical future, in the context of the reality of this world we're living in at this moment, and remembering that we could move into a world with no effective antibiotics left. Today, we're living in a world with an untreatable virus. The global scale and scope is unprecedented in our history. And we are seeing, albeit a fractured approach, a global approach to tackle it, not least through the landmark agreement between 156 countries to agree a deal for global vaccines when one is found. One that's safe, one that works. We're seeing right now that the global health threats don't respect borders, and nowhere will be safe until everywhere is safe. The same holds for antimicrobial resistance, or AMR, that we're talking about today. It goes without saying, we need collaboration and global mobilization to address it. And whilst it's too late to prepare for COVID, we can prepare for the next pandemic, and we can act now to address antimicrobial resistance before it's too late. And actually, that's why I'm so proud that 135 countries have finished writing their own national action plans to address AMR, and 50 more are in the process of developing them. This gives us all a plan and a way forward. I hope that we can work through the United Nations system and as an international community to keep AMR on the agenda and act with our full force as governments, organizations, academics, and investors. There's lots of collaboration already going on, and Hanan will tell you about what we affectionately call the tripartite: the WHO, the Food and Agriculture Organization, and the Organization for Animal Health. Until Easter last year, I was one of the co-conveners of the UN Interagency Coordination Group on AMR. And with representatives from those international organizations and many others, we worked with individual experts and we gave our recommendations for global action and local action to the Secretary General. But it's clear that global action is needed, and it needs to be systemic, structured, systematic, and it needs a One Health approach to AMR, at the global level, the regional level, the national level, and the local level. And this needs leadership and accountability at each of those levels and collaboration with new stakeholders too. For some, it's very difficult because we're going to need the private sector to play a really big role. They underpin our food chains as one thing, but as we've seen in COVID, they play even bigger roles. So we've got to reassess our global and national approach to AMR in the light of COVID. We need to reshape our approach with the knowledge of what we're seeing today, with the lessons of what work and what don't work. And we, above all, need ambition and experimentation. And we've got to share best practices. If we don't act, we should not underestimate the threat of AMR to modern medicine, to our lives, or, as COVID has shown us, and we knew anyway about AMR, our economies. AMR is a serious threat to humanity and our planet, with the potential to be far, far more catastrophic than COVID-19. Though politicians are finding that one a difficult one to hear because they're facing the here and now. But we need to keep it up there. And without urgent, concerted action, by 2050, we'll have 10 million deaths a year, a 3.5% reduction in global GDP, and an extra 28 million people forced into extreme poverty, let alone not delivering on the Sustainable Development Goals of the UN. This is not a future we should be contemplating. We should strain every sinew to prevent it happening. But if we take the lessons from the current crisis and start with preparedness and prevention more seriously as a global community, I believe we've got a fighting chance. You can see the sun has stopped pouring through my window. I'm so proud of the efforts that we're leading in the UK. We've even launched a new system to pay companies for antimicrobials based on the value in a health technology assistant of those antibiotics to the whole health system, and we'll pay for that by subscription rather than by pill. That is groundbreaking. But the UK is a small market, a small country. We need other people to join in or to experiment and to find ways to persuade the drug companies to develop new antibiotics. And we should never forget that we need each other. We're all trying new things, trying new ways of working across boundaries. Some of it is carefully thought through experimentation, some's a bit hit and miss. But if we don't try, we're never going to know. If we know, we have a duty to share, and we won't know the impact of AMR if we don't get moving and try and sort it. We need better and more surveillance to empower clinicians and patients to conserve antimicrobials. So today we're focusing on surveillance. We know it's going to be pivotal across the world, so we can identify what's driving AMR, where we are, and we can move to change it for the better. I'm proud too about our UK Fleming Fund investing in 22 countries to collect and share AMR data across sub-Saharan Africa, South Asia, and Southeast Asia. But we need more countries, more sectors joining in. So as our discussion today focuses on monitoring, particularly global monitoring, particularly appropriate at the UN General Assembly, and how data sharing can evolve, we need to think about how the world can combat AMR with a truly global One Health response. We all know those consequences if we don't act. So let's think about how we can do it. So I'm going to talk for a few minutes to each of our panel. Then we're going to open up to the whole panel for general questions, and you're going to join in. Otherwise, it might be a bit boring. So, of course, you'll join in. And this is different from many panels because we're not having big presentations. Most people are already interested in this area. And our job is to make sure that you leave feeling ready for action and with some ideas how to do it. So I'm going to start with Dr. Hannah Balkley. As I said, she's the ADG at the WHO, but she, before that, ran the World Health Organization's Collaborating Center for Infection Prevention and Control in AMR. She's had many roles. She is truly expert. I look to her to guide me on the technical issues quite often. And most recently, she's been given an honorary ESCMID title. And I know that's very special. So congratulations. Hanan, welcome. And thank you for joining us today. It's absolutely clear that COVID-19 has shone a light on the importance of global surveillance in the management of disease outbreaks. So let's begin by asking you to reflect on the changes we've seen in global surveillance in response to COVID-19 pandemic, which you think could be relevant to AMR. What should we be looking to keep, to capture, to enhance, to expand on, to help improve our understanding of the global prevalence of drug-resistant infections? Hanan.
Thank you very much, and good afternoon, good morning, good evening for everybody around the world. It's really a true pleasure to be with you, Sally, again on yet another big AMR event with your inspiring words. So thank you very much for having me. I think to answer that question, it's very important that we set the stage, because this is not the first time I've been asked this question, is to set the stage. What is a bit different between COVID and what's happening versus what we're going to be facing in AMR? So I think I would like to start by saying a few of my own reflections. Number one is COVID is really a visible disease to everybody. It grew fast, it popped up fast, it got the headlines. Unfortunately, that has not been happening with AMR on a consistent way. Number two is that we do have to be optimistic. We do know that there will be a closing for COVID. Either we will become immune, whether it takes a year, 2, 3, 4, but we know it's one disease. Humanity will build immunity to it, or it might slow down a little bit if the virus transforms or goes through some kind of genetic transformation. That's not going to happen with AMR. In fact, it's the opposite, where pathogens continue to develop new resistance genes, and they actually share, they cheat, they actually give each other these enhancement discs, if you will. The other thing is that the implication of COVID has been super strong, super visible, whether it was on the healthcare systems or whether on the economical side of the globe. And it really caught everybody's eye, from the physicians to lay people, to economists, to financiers, to bankers, to every single person talks about COVID. And again, that is not happening with AMR. So I think one of the biggest challenges that we, again, the AMR community are going to be put under is we're going to be shamed, if you will, about how come we're not doing how come AMR is not getting the attention as COVID. Well, they're two very different beasts. And that's why I'm so happy to see that we're going to be having people on this platform in the hundreds, because we do need to have this dialogue. We do need to bring AMR to the forefront. So how can we capitalize? The AMR community needs to learn how are we going to have a stronger engagement. Now, a lot of the resources, whether in the healthcare facilities and the laboratories, have been repurposed to address the situation of COVID. Can we repurpose resources for AMR? Because we know that they're kind of slim, whether it's lab capacity, IPC, stewardship people in the human, then even more scarce in the animal and in the agriculture world. How can we repurpose? We won't be able, because repurposing is assumed to be for a short period of time. We need to help build capacity for the long-term sustainability of these services in the different areas: animal, human, environment, water, and so on. So I think what we need to learn is how can we be innovative in creating a hot platform? We have to create the urgency. And hence, I'm assuming that's why you very geniusly chose surveillance as the topic of this discussion, because without surveillance, without data, without understanding the scope of the disease, we will not be able to create the attention and bring the spotlight back to AMR. And that's why I think this discussion will be very relevant, and I'm happy to go on in different areas in the next questions. But I think we need to figure out how we're going to capture the data that is relevant, reliable, and reflective of the reality of antimicrobial resistance in the different sectors, and to use that data to create the burden of it. And again, talking about burden, we could talk about Is it mortality? Is it morbidity? Is it, is it economical burden? We need to get into all of those areas. And then we need to be able to use that data and the surveillance data specifically to create the platform and jump from there. But the challenge is, while we're doing that, the other areas of infection control and stewardship and research and development and innovation need to continue. So I hope that's relevant for the first question, but I can go on based on the dialogue. Thank you, Sally.
Well, that was pretty exhaustive, but thank you. A good start, just a bit too long, so you're going to have to be shorter the next time. It's funny, as we talk about this, I've been describing it as a lobster, and COVID is the lobster dropped in the boiling water, and it's making a big noise, and everyone notices it. AMR is the lobster in the cold water that's slowly heating up. It's going to die, but because it's doing it slowly and quietly, people aren't taking enough notice. So, in only a couple of sentences, in the light of what you've learnt from COVID-19, what are WHO and tripartite's current priorities for surveillance activities in AMR?
I think we can divide it into two main areas. If I talk about the human health perspective, the surveillance, as you know, the main platform from WHO is GLASS. So in trying to look into what GLASS, what we call it 1.0, is looking into an upgrade by trying to address the fact that GLASS has not been able to support mid-low income countries and bringing the ability to present that data in a reliable and accurate format. So there will be a major consultation process among the collaborating centers and member states. We have 95 countries engaged so far in GLASS. So we are looking forward to support the countries who are already there on moving into more bugs, more drugs, more whole genome sequencing, more relevant data. And the mid-low income countries, how can we be innovative in creating maybe surveys, different methodologies of collecting data that will be reliable and representable? Because again, that is what is needed. For the tripartite, the TISA platform will hope to create a platform that we can aggregate data from agriculture, water, and environment, and that's a little bit infantile, so maybe I won't elaborate too much on it, but that's the vision.
Great. So what we need everyone on this webinar to do is to watch your website when the consultation goes live, and then they lobby their governments to make sure their governments say the right thing. So a final question. What is the one thing that the people on the webinar involved in national or local surveillance should prioritize so they can spot outbreaks and develop local or national policies to address such outbreaks? One thing.
I think they need to lobby resources and leadership. They need to lobby to have leadership to move this agenda forward. And that's the one thing that I think will help.
Right. I know how difficult it is to lobby leadership. So thank you for the starting. I'm going to move to Rogier now. And I want to introduce him. As I told you, he works as a clinical microbiologist in Hanoi. He's hosted by the National Hospital of Tropical Diseases. And what's so terribly impressive about Rogier's work is he goes from a research program covering the spectrum from laboratory detection of resistance mechanisms even through to implementation research. And I've seen him in action on the public and policy engagement. And you've set up this network of 16 hospitals, which is great. So, Rogier, Vietnam is your area, yes. And we've heard about global and country surveillance, but I want to ask you, because you've got this experience of local and regional surveillance, can you reflect on the changes you've seen in response to the COVID-19 pandemic, which you consider relative to AMR? Again, this question, what should we keep, enhance, expand on to help improve our understanding of global prevalence of drug resistance?
Yeah, thank you. I'll answer it from the Vietnam perspective mostly, as I've been here all the time during COVID, and I've seen the response that we'll hopefully talk about a little bit more later. I'll probably be a little bit repetitive of what Hannon said, but I'll give my answer.
It gives an emphasis then to it.
Exactly. Talking about surveillance of an acute respiratory viral infection is a different thing than talking about an endemic problem, as AMR unfortunately is already. The response in Vietnam has very much been to try and stamp out COVID-19 or SARS-CoV-2 entirely, and therefore the surveillance that's being put in place as we go along this outbreak here needs to be able to detect every single case. Whereas when we're talking about AMR, you're talking about assessing the burden and nature of drug-resistant infections as an endemic problem. So difficult to compare. What I've seen here, what has happened, has made me slightly jealous in the sense that, and I'll use the word repurposing again, as Hanan did, in the sense that so many things could be repurposed to address COVID-19, which we sometimes dream could happen for AMR as well. So I've seen very rapid scale up of ARI surveillance in hospitals to try and pick up every case of respiratory infection caused by COVID-19. I've seen the incredible scale up of diagnostics. Vietnam's done 1 million PCR tests while having had only less than 1,100 cases. So that scale up of diagnostics is very, very impressive over a period of a few months. And also, and more relevant to AMR, incredible scale-up of infection prevention and control measures in hospitals where patients are and where they need to be isolated. And Vietnam not only isolated patients, but they also quarantined contacts up to a second degree of contact. So several thousands of people have been in quarantine. And there was also a really intensive system of tracking and tracing and isolating of people who had been exposed or potentially had been exposed. So, yeah, thinking about what all has been put in place, the massive screening that has been done, you wonder if some of these things may be considered to be done for AMR. If you screen everyone coming into a hospital for COVID-19, can we not also screen them for carbapenem-resistant Enterobacteriaceae, because they also spread into hospital and they also cause massive problems and they also have high mortality? And same for the very intensive infection prevention and control measures that I've seen. So the repurposing that was done for COVID-19 would be great if we could think of repurposing some of these things for AMR as well. The biggest difference, I think, that I've witnessed was how a public health emergency can be prioritized, can be put on top of the national, but also the international and global agenda. And COVID-19 has managed to do that. And I think there's a lesson to be learned for us how to do that for AMR. I'm a member of the CEDRIC board, one of the sponsors of this, or one of the enablers of this forum. And it's our job to analyze data and to advise and to advocate on AMR. So it's a job for us, I think, to think about this and how we can put a similar spotlight on AMR as has been put on COVID-19.
Thank you. So there was Vietnam implementing quick policies to prevent COVID-19 spreading and having great success. You've said one key enabler had to be the prioritization, and another was the ability to repurpose. But can you talk more about what made these things possible and how we could apply this to AMR in other countries or in Vietnam? I mean, how can we get Vietnam to be the leader in AMR as well?
Okay. I'll talk about the response of Vietnam a little bit. Give some examples of what was done and what were the things that really stood out of what was done, because it's been a uniquely, well, almost uniquely successful response. So just a bit of background, we've had, so it is a country of about 100 million people, and there have been 1,069 cases exactly, and 35 deaths. And the last case of community transmission was the 2nd of September. So we've been COVID-free for more than 3 weeks now. The response was characterized by incredible speed. So even before the first cases came in, and the first cases came directly from Wuhan, China, there were already health screenings in place, and there was already talk of restricting entry. Also, before the first cases were there was very consistent communication from government throughout the whole country about the disease and about ways of preventing it. So there was a very early awareness among the population, and as you and many others will know, it's wearing masks to prevent respiratory infection is fairly common in Vietnam and other parts of Southeast Asia and the region. And so that was a lot of people were wearing masks immediately everywhere fairly soon during the awareness of COVID-19. Border closures were implemented increasingly, and by the 21st of March, basically all borders were closed, and everybody who was coming in was checked and quarantined for 2 weeks. We've had a brief national lockdown of 3 weeks, in early April, and that stopped the second cluster. And after that, we were COVID-free for almost 100 days until there was another outbreak that is now again under control. And what was most striking about the response was that there was a lot of testing. I mentioned it already. 1 million people, 1 million tests were done. But the response was based on epidemiology, based on exposure rather than on symptoms. So it was not sick people that were tracked and isolated, but it was their contacts up to the second degree. People were tracked and traced and then isolated for 2 weeks and tested at the beginning and at the end. So yeah, here we are now with the last outbreak emerging from Da Nang. There were 500 cases, and that was under control in a couple of weeks. So now we're again 3 weeks COVID-free. And your question, what can we learn from this, from COVID-19? I think for AMR, I think it's difficult to implement all these measures in the same way for AMR, but it's again the scale of the repurposing that is striking, and the way the urgency of the situation was communicated, and the way the whole population was aware, but also everybody was participating, right? Everybody was wearing a mask. There wasn't a single shop that you could enter without a mask. Every shop had a little alcohol pump in front of it. So there was a collective awareness and a collective sort of way of doing things about it that was really different. You mentioned the lobster. I was going to talk about the metaphor of the frog in water that slowly gets hotter, and the frog that doesn't notice it, as a metaphor for the acute respiratory infection that speaks to the imagination, whereas AMR is sort of more of a creeping problem. It's difficult to bring that same message across for AMR. Vietnam had the experience of SARS-1, had the experience of H5N1, so those viruses, we are aware of them, we know how to deal with them, and when it happens, we try to fight them in such a large way. And so, looking at AMR and looking at SARS-CoV-2, I looked at the numbers today on one of the apps. It was 987,000 deaths today. But referring back to the O'Neill report that you know all about, it's currently 700,000 for AMR, which we all also know is an underestimate because it's extrapolated from the USA. And low and middle income countries probably have a higher burden. So it warrants a similar response.
Thank you. Yes. So there will be something about how can we keep hand sanitizer going and mask and washing hands going after all of this. But give us some advice. There you are in Southeast Asia. Capacity is critical in low and middle income countries. What one thing should we be suggesting they do to build better surveillance systems for AMR?
Yeah, that's something I and other researchers here in the region in my network have been thinking about and have been trying to find solutions for. A lot of the surveillance is based on getting microbiology data from the lab, but getting them passively. So we basically collect everything that is generated. We know that microbiology is underused in most of these laboratories in this area. Not everyone with an infection gets their testing done. No, it's usually the people who are not responding to antibiotics, who are more severely ill. It's people who are transferred from other hospitals and are already on antibiotics. And all that does is selecting towards more resistant bacteria. And then if you generate surveillance data that say 70% of bacterium X is resistant to drug Y, and you could start to use that for your clinical guidelines, you're actually advising to use more broad spectrum antibiotics than is really required. So what I would suggest, and what I'm also trying to do in a number of research projects, is not just collect that clinical microbiology data, but also get the clinical metadata to accompany it, so that when you have the data, you can take apart community-acquired infections from hospital-acquired infections that are usually much more resistant. And then you can look at the real data per syndrome and use those data for clinical treatment guidelines. And then you get a much more realistic picture, but you also don't have the risk of recommending more broad-spectrum treatment than really required. So you get a more focused set of data that can really help doctors in making their decisions and their treatments.
Thank you. So great start. We'll be coming back to you in the discussion. I'm going to move on now to Dr. Michael Osterholm, who, as I said, is the director of CIDRAP in the University of Minnesota. A lot of accolades, but many people know him as the author of the New York Times best-selling 2017 book, Deadliest Enemy: Our War Against Killer Germs. In that, he not only details most pressing infectious disease threats of our day, but lays out a 9-point strategy on how to address them, while preventing a global flu pandemic's at the top of the list. So that kind of primes my first question to you, Michael. What are your reflections on the changes we've seen in global surveillance in response to the COVID pandemic that you think are relevant to AMR? What should we keep, enhance, expand on? How can we do better? Over to you.
Well, thank you. First of all, Sally, again, it's a great honor to be with you, and thank you for all you've done on behalf of all the citizens of the world in this regard. COVID-19 shines a light on surveillance and the importance of data to inform life-saving choices and practices at all levels. And I think that's one of the things we have to continue to understand at all levels. You know, we went from not knowing and speculating on the effects that COVID-19 might have on bacterial infections and AMR to knowing a little bit more about disparities between rates of bacterial and fungal co-infections and antimicrobial use, and in the short term. The disparities we see over and over in the literature show how important it is to pay attention to diagnostic and antibiogram data at the local level. As you know, in recent studies from around the world, we're seeing rates of bacterial co-infection from around 6% to 30% at admission. And that really illustrates the urgency surrounding the fact we need to know better into doing better. Knowing that a small or large proportion of people receive antibiotics that have bacterial infections doesn't help a clinician identify the person who might really need antimicrobial treatment. We need to take this data we've been gathering and use it, not just to illustrate the most COVID-19 patients won't need empirical antimicrobial treatment, but to inform practice on how to identify the patients who really do. We especially have to be aware during conversations about COVID-19 and AMR surveillance that AMR has not just stopped because COVID showed up. You know, the WHO estimates that about 700,000 people die each year due to drug-resistant infections. 230,000 of those deaths can be attributed to drug-resistant tuberculosis. Given what we know, there's no excuse to ease our focus on surveillance for diseases like TB. It's also estimated that in 10 years, the effects of AMR will force 24 million people into extreme poverty. And COVID-19, as it moves through these very same communities where poverty will be such a significant issue, has revealed that we are really both succeeding in some instances, but often failing. That's really where we need to turn our attention, I think, translating the growing body of surveillance data into practice. If we've been enhancing our surveillance networks and gathering data, but not building systems and ways to learn from it, and to provide better care, surveillance is really useless. I think we need to stop thinking about drug resistance as a global phenomenon. Yes, let's call it a global phenomenon with many different local faces, because there is use in having global standards that give direction to local efforts, as we've seen with the Global Point Prevalence Survey, quickly adopting its protocols to carry out surveillance antimicrobial use in COVID-19 patients. But we've watched COVID-19 affected communities around the world so differently depending on governance, healthcare systems, testing capacity, disparity with long histories, and how people behave. Literally all aspects of culture come into play. COVID-19 might be a pandemic, but if you don't see it and treat it as a local phenomenon, then you're missing a lot of the information that's going to help you prevent new cases, be reasonable about the likelihood of bacterial co-infections, and keep your eye directly on the rates of drug resistance. We need to keep and cherish the flexibility of local antimicrobial stewardship and AMR surveillance programs as they continue gathering enormous amounts of information and adapting their activities to make improvements that balance patient care. And the key thing is the COVID-19 pandemic has shown a light on the fact that AMR and antimicrobial use surveillance are necessary, especially at a local picture. But resilient systems to respond to that information, have the freedom to do something about it, is what we should be aiming for. And I think that's yet where we're still falling short.
Fascinating. Of course, you're right that for all the focus globally to try and raise awareness, the actions locally, what does it mean? How do you handle it? How do you learn? So remembering that, what should our global priorities be in the light of learning from COVID? And how can we use the surveillance data to support policy making?
Well, you know, we've started to see a lot of efforts in the area of translating surveillance data to policy making in the last few years as we've started to think more about antimicrobials as part of the global commons. You know, a dear friend and colleague, Dr. Martin Blazer, was here at the University of Minnesota several years back. And in one of his talks, he said, if I prescribe a cancer drug, I affect the health of the patient. But if I prescribe an antimicrobial, I affect the health of the world. That, to me, is at the heart of why we carry out surveillance and why we must ensure that we're invested in a system to put it in use. These systems must include governance, policymaking, and financial investment. You know, I mentioned earlier that both COVID-19 and AMR surveillance can be more effective if you see them as local. But surveillance also represents an extraordinary opportunity for global data sharing and adoption of worldwide standards to serve local policy, especially in the areas that we're working to build surveillance networks and standardized operating procedures. One global priority includes focusing our attention on surveillance gaps that, if filled, might give clinicians decision-making basis for managing drug-resistant infections or inform the development of evidence-based guidelines. I think it's also important to look at where we can connect and share information across public and private healthcare systems, particularly in low and middle income countries. And we need to be conscientious about inequities surrounding access to data, research publications, and funding opportunities. Improving surveillance is as much about realizing whose voices are missing as it is about using the available data. So if you start connecting the dots between AMR and I think directions that policy can reasonably take, solid governance is achievable, often slow, but it's never impossible. And there are always opportunities for sharing data, skills, and practices. Government and policies are tremendously important. We all have power to affect change when we come together and start talking about what we know. One group's knowledge may be the answer to another group's previously unresolved problem.
Yes, and I think we'll probably come back to sharing data because COVID has changed what we do. So as I've asked our other colleagues, one thing that those who've logged in today could prioritize to help build that better picture of disease burden locally, what would you suggest they do?
I think we all have to participate in what will be a very obvious post-pandemic review. You know, in some ways, I look at the current situation with what's happened with our lack of preparedness for this current pandemic and the fact that there will be some group or groups that will be doing a postmortem on how well we responded or didn't respond. And for the first time, I think we're going to see the global inequities in response, as well as the fact that in many instances, we didn't have in place the surveillance tools, the techniques we need. And I think the AMR community has to be really involved in that postmortem because it will serve as, I think, the future model for how can we improve AMR surveillance in the future. And we need to be at the table when we do that postmortem to say, in fact, look at all the things that we're missing in the public health system, in the clinical medicine system that we can use today for better public health. And AMR should be a very high priority in that.
Thank you. I like the way you've framed that, particularly knowing that in Britain we're going to have a few postmortems, let alone at the global level. I'm not sure that too many postmortems gets us where we need, but thank you for that.
Thank you.
I'm going to now turn to the last but not least of our panelists, Dr. John Nkengasong. This gives me an opportunity also to thank his alma mater, the US CDC, for their support for this as well. And you will all know that he is the director of the developing rather strongly and well African CDC. And I'm delighted to tell you, if you didn't know, that this week he's been announced as the recipient of the Global Goalkeeper 2020 Award from the Bill and Melinda Gates Foundation for his contribution to disease control and prevention in response to COVID-19 in Africa. Absolutely well-deserved. Congratulations, John. We're all thrilled for you and for your African CDC, because it really recognizes your strengths. You've been championing the approach to minimize the social and economic consequences of COVID across Africa, bringing together global vaccine developers, funders, and local facilitators. You've really done a lot. So, John, welcome, and let me put this to you. The COVID-19 outbreaks highlighted the importance of country and regional surveillance in the management of disease outbreaks. Could you reflect on the changes we've seen in country and regional surveillance in response to COVID-19 and the pandemic, and then pull out what you think is relevant to AMR? What should we be keeping, enhancing, and expanding on to help improve our understanding of global prevalence of drug-resistant infections? John.
Thank you, Sally, for the kind words and for inviting me to be part of this panel discussion. And I thought that question would be, I'll start with the positive side of COVID, that it brought the continent closer to and working together collaboratively than we have ever done before. When COVID-19 was first introduced on the continent on February 14 in Egypt, we convened a meeting here at the AU headquarters, where the Africa CDC convened all ministers of health. And really, in a very remarkable manner, within 1 week, all ministers reported to Addis Ababa for an emergency meeting to discuss the threat. And that has never been done before. Within 1 week, and I recall that as we were planning that meeting, people walk up to me and say, John, why are you setting yourself up for failure? No minister will show up in Addis Ababa within 1 week. And they were all there. It speaks to that trend. But the key outcome of that meeting was that they agreed that we need to collaborate, we need to cooperate, we need to coordinate our efforts, and then we need to communicate better. Aren't those key elements that we need to fight AMR across Africa? I mean, the ability to coordinate our efforts, to collaborate, and to cooperate across the board. So a technical working group, a task force was established, and that brings together all national public health institutes that look at about 5 or 6 areas there. One is infection control, second surveillance, third lab and subtyping and genomics, and supply chain management, research and standards. Does it sound familiar? Yes, those are all elements that we need to support AMR. What is new in this architecture is that it brought all of this together, such that someone in Nigeria like Dr. Chikwe is forced to talk to me every week, and then we are all forced to talk to each other with someone from Morocco, from Tunisia, from South Africa, every week, 4 p.m. on every Tuesday. We discuss that. Imagine if we brought that architecture to bear to support AMR work. And that way, it's not fragmented, but it's all coordinated, and we're all singing from the same hymn page there. I think that is clearly what we have learned from COVID, and it's a bright side of COVID that it has pushed the continent to come together, and we can use that framework, that mechanism and architecture that we've put in place to really put it at the disposition for surveillance for AMR in an integrated, coordinated way on the continent.
It's interesting you frame it like that, John, because I always say you build trust by working together. So you've just demonstrated that with your leadership for Africa. And I do hope you just continue working through on the AMR bit, because you have shown you can make a difference and it'll really matter. So moving on from that, you've learned from COVID-19. What are your priorities for surveillance in AMR going forwards?
My priorities for surveillance for AMR is really what COVID has taught us. I will be surprised that the continent of Africa will come out of this crisis looking the same like we went into the crisis there. What I mean is that we should use the challenge that COVID has imposed on us to really strengthen our national public health institutions and push every member state to have one. That way they become the house of surveillance for AMR. Okay, that way it's not dispersed all over, but it's centralized there and then coordinate within each country and then coordinate within each sub-region and coordinate with the Africa CDC. You need that architecture, that framework to drive AMR surveillance going forward and learning and borrowing from COVID-19. So I think I like your analogy of a lobster. COVID-19 is up there, a big splash, and then AMR is down there trying to find its way. I think we should really build on the back of what COVID has done, which is it has brought the challenges to the attention of the highest leadership of the continent, which is the level of the head of state, where every 4 weeks or 6 weeks, they all come together and they say, well, John, tell us about where are we with our pandemic? What should we do as a continent? And so if you say to them that, look, you need to invest your own resources in building your own national public health surveillance system, because you should be anticipating that COVID will be over and you use it for another challenge. And that challenge may as well be AMR, which without saying that you have to prepare for AMR, say we have to build that infrastructure to use it for another challenge. I believe will be coming out different, and you can use it to fight this, the AMR, which is an incredibly dangerous threat that we are facing.
And it's interesting, we all face the same challenge. In Britain and the United States, we're going to have to rebuild public health, just as you are in Africa, to make it stronger so that we can deal with these things even better. Though I think our lot were doing quite well on AMR, but they can always do better. I'm always asking for more. So many people on this webinar, I don't know whether you managed to get on when I said there are over 4,000 people who were logging in. So many of them are involved in national and local surveillance. What's the one thing you think they should prioritize or would advise them to prioritize to help build a better picture of the disease burden so that we can spot outbreaks and develop national policies to address them?
I think the one thing that, let me maybe, Sally, say this before that. The COVID is unprecedented, but it's not surprising to all of us, right? I think if it was surprising, there was no point that we were all talking about global health security, and we have been saying this forever, and AMR is part of the global health security agenda, I think. But I think we talked more than we actually invested in that whole framing. I think this is a time to say, if the one thing I would ask is that, let's put our pockets where our mouths are. And this is not just an African looking for resources from the West. It's saying you start from Africa and say, look, put your own resources into this, because we've now seen that the failure to prepare is preparing to fail. And we have to invest into our health systems before we need them. You don't build health systems when you need them. So I think that would be my one ask to them, is put your pocket where your mouth is, in terms of the health security of our continent.
That's great. Thank you. So what we're going to do now is put the four of you on the bridge, and you'll not be able to see me, but I'm going to ask you questions and we're going to have a conversation. And by all means, have a conversation with each other. But actually, while they're organizing the pictures, John, let's you and me continue and then join in the others about health security, because I have been framing AMR in Britain as an issue of health security. But a lot of people have said, oh, I don't know that we should call it health security. But with COVID here, you're talking about it as health security. Do you feel comfortable calling it health security? What do the other panelists feel? That do we get to where we need to by calling it health security, or should we frame it a different way? But John, do you just want to pick up before I hand over to the others?
I would say in no apologetic manner, yes. AMR is clearly a health security issue. It is not a national health security issue. It is a health security issue. I think there's a clear difference. If your report, the only report says that by the year, I think 2050 or so, about 4.1 million Africans could be affected with this, and if nothing is done to change the trajectory, affected meaning mortality, then I don't know what else can be defined as health security. Health security should not be only defined as the ability for a disease to originate somewhere and become and affect you somewhere else in a geographically different region. It should truly be defined as, what is the impact that is going to have on that individual and the society and the community that individual lives? I think that is going to be important that we agree on basic definitions. Say, put it this way: if person X has an AMR and you can't treat it, and you're spending a tremendous amount of your resources trying to treat that individual, and you cannot, and that person is the breadwinner of the family and doesn't succeed, then it's damaging not just to that individual, but damaging to the society and the community that person is there. And if that is not a health security issue, then I don't know how else we can define health security. Again, we should come out of this crisis saying health security is not just something that originates somewhere and threatens me where I see it, but something that locally, health security starts with local security and regional security.
Great, you framed that beautifully. And of course, if you've got extreme drug-resistant TB, at least with British prices, then it costs 80 times more to treat that patient. So it becomes a cost issue as well.
Exactly.
So, Hanan, health security. I'm going to ask the other two as well, because it has sent some people flying off, a bit scared. Oh dear. Where do you think WHO is on it, agreeing what John and I think is plain obvious?
I think I'm on the band with that one, and WHO as well. As you can see, as part of the international health regulations, AMR is part of the JEE, the Joint External Evaluation Assessment. So AMR is in there, and the scoring card for it again, which we were looking at for the COVID, the preparedness part of the countries to respond to emergency situations, including pandemics. We can see even with that assessment, and I like what John said about a post-mortem, we can see that the countries who actually scored well for preparedness on pandemics did not do well still, which means that even if we did have that for the respiratory pathogens, you can imagine how deficient we are in the contact transmission pathogens, or the MDROs, if you will. So I think there's no question that it's a security health issue, or a security issue, if you will. I think the WHO, as part of the GLASS platform, we've established the emerging AMR reporting process, because just to allow me a few seconds to elaborate on the disaster with the multi-drug resistant pathogens is we see them and we don't detect them for a long time. Then someone does a whole genome sequencing, identifies a new resistance gene. By then, everything is spread and it becomes more endemic. So we're trying to establish a platform where we can pick up these resistant pathogens in a much quicker fashion. And that will require, again, enhancing the national level surveillance and diagnostic abilities. So I hope that that's helpful, that response. Thank you.
Well, I think it is. But Michael, do you agree?
I do. I would offer a friendly amendment based on our current experience. I've been struck by how many people in our own discipline have said how surprised they were by this pandemic. We should have been challenged by it, but we should never have been surprised. Why were we surprised? Situational awareness was very low in many instances in the public health world. I think that my friendly amendment to this, Sally, is that it is really about health and economic security. And I think they go hand in hand. People now realize after this pandemic what public health and health means to the economies. And we need partnerships out of the private sector that aren't necessarily tied to health as we know it, but everyone who is a member of that company, of that organization, has health at the very basis of their operational structure. If their employees and their customers aren't healthy, they don't have a business. And so I really think we need to capitalize more on this issue. And, in the book that you very kindly mentioned, I actually tried to raise the issue of AMR up to that of a pandemic, where we have the acute pandemic that we're seeing right now. But frankly, AMR is an insidious pandemic, not one organism, but it is literally crawling around the world, creating what will ultimately be nearly as devastating outcome as we see with an acute pandemic like COVID-19. So I really find that helping my colleagues understand its health and economic security, and that they should be linked arm in arm, as I think an important way to go forward.
I like that, and I absolutely agree, which was why I persuaded David Cameron to commission the O'Neill review, clearly. But isn't this interesting? Here we are discussing this, and I have 4 microbiologists in front of me on the screen, and I'm a hematologist. Public health has been found wanting on COVID and AMR, hasn't it? Mm-hmm. So, Rogier, what are we going to do with public health? This wasn't on my script, by the way, but hey, this matters. What are we going to do with public health?
What are we going to do with public health in terms of AMR?
Well, start with AMR. But clearly, if they're surprised, and I agree with Mike, about COVID, and we've, in the North, had a very slow response, public health needs a bit of kick up the arse, shall we call it?
Yes.
What kick up the arse would you give public health? Arse, for those who don't speak English, is the backside.
It's a difficult question, Sally. But no, I agree with what Mike said earlier, that AMR is a pandemic, and it has been a pandemic for a long time. We now have, we globally have experience of going through a pandemic. So I think we can use the same phraseology of this pandemic to help prepare and help kick public health up its ass, as you said, to implement more measures to do something about this one, about this coming one that's already among us, but will only get worse.
So we're getting a number of questions. Let me, and a couple of them are linked. The first I'll put to you is the value of antimicrobials is a powerful concept. The second one related is the role of pharmacoeconomics, is there a role for it in antimicrobial stewardship? And I just wondered what you all feel about this. How we clearly haven't valued antimicrobials effectively. We're talking about health security and economics. How do we put all of this together? Hanan, I bet you've thought about this.
Thank you, Sally. I think, again, these are very difficult questions, as you can see, and I'm sure that you've also thought about the previous one with the public health agenda. The problem with AMR, in my opinion, is we really have not been able to give it the urgency that it needs. Again, we didn't discuss here a little bit, none of us, if I remember correctly, have talked about the lack of access to antimicrobials. So it's not just about antimicrobial resistance. It's about, if you want to make the center of the discussion the antimicrobial itself, the value of it as a global health good for everybody. So giving it to the right people in the right time is extremely important. So I think giving it the context, I become sarcastic about this sometimes when I speak to our colleagues and even to lay people in the family, You'll never have someone given an antihypertensive or an anti-cancer therapy without them being diagnosed with cancer or hypertension. It's very unusual. Yet an antibiotic can be given as a gesture of love, as a gesture of care. They use it as a gastric cleansing agent, a growth promoter. When it might help infections and cause growth, but it's a growth promoter. It's the second level, right? So I think we need education, and that's why one of the first pillar of the global action plan is awareness. And if you dive deep into that, we need to do a much better job. And maybe this is an opportunity for me, from one of the questions you asked before, is the tripartite is working really hard in revamping the world awareness, the World Antimicrobial Awareness Week, which will happen in November. And it has been done jointly with a very extensive consultation with tripartite civil society member states. So I think that piece is a big missing piece of the puzzle.
Yeah.
Thank you. So here we are talking about the value of antibiotics. Mike, have you looked at the value of antibiotics at any point? What do you think we should do? Because then we want to talk about how it impacts the value and how it can be thought about in the low and middle income countries.
Well, I think that when you use the word value, which is very appropriate here, it's like the word love. It means a lot of different things to a lot of different people. And I think one of the things we've never really established is, what do we mean by value? And I think that for many people, we still have a challenge in the education side. And I have really gotten away from the concept of general education as a way of really dealing with this issue. Let me give you a case in point with COVID-19. We estimate that up to a third of the United States citizens do not yet believe this is a pandemic. They think it's a hoax. Now, I don't know what kind of education opportunities we could use beyond what's been done to help people understand that this is in fact real. It's a public health challenge, and your actions put you in harm's way if you so elect to not take the precautions we've recommended. So I don't count on the public necessarily for being the action population for steps. On the other hand, if you look at our country, and this is nonpartisan, it has nothing to do with anyone's potential political leanings, but if you look at, we have 49 states in the District of Columbia in this country that have had ongoing serious challenges with COVID-19 that right now, Sally, right here in our state of Minnesota, we have almost 5 times the level of COVID-19 that you do in England. And yet look what you're doing there, and we're actually releasing more of our population into everyday activity. And what you look at is what happened in New York. After the house was on fire there in April, Governor Cuomo put together an incredible program of surveillance, of action, of taking the data at the finest level and every day looking at those data and making decisions about what can be done and couldn't be done. And right now, New York has gone more than 40 days with below 1% positivity. They are opening back up, et cetera, because somebody took a leadership position and oversaw that. They didn't count on the masses to come to agreement. This is what we're going to do. I think we need to look much more carefully at the AMR issue in the same light. I'm not going to count on 30% or 40% of the population necessarily to understand it and to abide by what we would call, good stewardship practices. But I want to find where in the system can we basically exercise the kind of authority, kind of power, and the kind of efficient decision-making that will limit the impact of AMR, and to make that happen. And I think that COVID has taught us a lot about that very issue.
Thank you. Yes, I find that really interesting. So last week, I launched with 22 founding partners the Trinity Challenge, and it brings together Microsoft, Facebook, Google, Tencent, lots of academic centers. And what we're doing is using data to explore and learn the lessons from COVID and how we can get at these things. And one very exciting project is one that started between Facebook and an NGO, Internews. And that NGO's job is to try and help get true news, as opposed to false news, through to places where it's very difficult to get news to. And they're helping Facebook try and understand how to give messages So they're heard, understood, and acted on, and thinking about what platforms and how to do it. So I agree. I've launched a big coalition and challenge. So log into the, I do it for free. So I'm advertising it because you can join in, and please do look at the trinitychallenge.org. But let's go back to our question about this value of antibiotics. Roger, the value of antibiotics in Vietnam, how can we help them value them? Because if you value the antibiotic, you might value not having it, or is that a double negative?
So antibiotics are available over the counter here in 60,000 private pharmacies, and they're used on a large scale. That in a way says that people value them and people want to have access to them, and people take them a lot. But that's not appreciating the true value of them. So I think there is a strong call required, a strong advocacy required to put restrictions on the access to antibiotics here, and make sure that they can exercise what they do at the place where they should be doing it, which is in hospitals for sick people, and maybe in outpatient departments as well, but to a lesser scale than it's being used at the moment.
So sadly, we've lost John, I hope temporarily. We've got a project going where...
I'm on. So I'm on.
Oh, John!
Yeah.
Jolly good. This discombobulated voice. Talk to us about the value of antibiotics in Africa, and do we need to do more work? How can we make it real for low-income countries?
I think let me discuss that in the context of COVID, that there are at least 3 things that COVID, we may actually learn from COVID and apply that to AMR in Africa or in resource-limited testing that would really have a substantial effect. I call it back to basics. So the first thing is that who knows, and just who knows, just because we are now so much focused on washing our hands all the time, washing it like 10 times a day or more, it could be the start of reducing AMR in Africa or resource-limited setting. I have something in me tells me, which is not yet proven by any data, that this effect of extensive hand washing is going to be critical in our own ability to fight AMR. The second thing is the community. And how are we going to harness the huge community mobilization that we have put out there, and with community healthcare workers and others? How can we build on and to expand the key components of basic hygiene and use of antibiotics there? And lastly is really what COVID is showing us is the exposure that Africa needs to build its own system for access to drugs, and including regulatory processes for substandard drugs. You know that one of our greatest challenge is substandard drugs. So if we build institutions, we capitalize on COVID-19 and build institutions like the African Medicine Agency that the African Union is promoting, it becomes a win-win for everybody. I mean, it's a win-win that it resolves some of our problems for emerging infections, but also addresses critical issues related to AMR, including antibiotics. So I think the point I'm making there is that access to antibiotics has to be very, very critical. How the community is educated and informed on the importance of antibiotics is critical. And then maybe, and just maybe, the hand washing piece is vital in that. So that's the way I see it, building on the back of COVID-19, which is very topical on our minds.
I think that's great. And our Fleming Fund, as you know, is active in many African countries. And we are asking for more money to continue, but also to help in this about falsified and counterfeit medicines and how can you help. So I think there's an interesting question for all of you, but let me start with you, Michael. there are bits of surveillance around, but we don't connect them up in time to have a network where we see the threats early enough to stop them, because glass is kind of post hoc. So glass is great for a kind of view of what's going on. What do we need to do to join up the bits that are there so it's real time? I mean, I'm going to come to each of you, but I think it's a very important question. We're debating surveillance. What matters is action locally. How do we join it up so we're all warned? What can we do about picking up the threat before it gets bad? Michael.
Yeah. Well, I think, take a quote out of the climate change world, think globally, act locally. And I think that one of the things that we need to do is continue to emphasize that this is a global issue. None of us for a moment dismiss that, but it is all local, as I said in my earlier comments. And I think it's the network of tying those data together and setting minimum requirements. I mean, think of it this way. There are minimum requirements for every air traffic control tower in the world. They know how to land planes and take off planes regardless of what country they're in or which country the plane is coming from. We don't have air traffic control standards right now for how we collect data, how we use data at the local level, and then tie that back into an international system for assessment and guidance and where we're going. So I think that is a mindset issue where we need partners today to deal with the issue of data. But again, we have to understand, as Sergio Sayas-Stamplin said, in talking about surveillance data in Old England, he said, in the end, they come from the village watchman and he puts down whatever he damn pleases. The point is we have to have data that's reliable that we can use into that air traffic control system. You never hear of a country use as an excuse, well, we couldn't afford to have an air traffic control tower like that. That wouldn't be acceptable. And so we need to have the same kind of mindset and same kind of support system for local surveillance data and how it's used and then how it's integrated into the international perspective.
Good one. Air traffic control, Hanan. We'll come back to you, but Roger, how about you?
I'll try not to be repetitive, but I think important to tie all the data together and to make it more valuable is to not only collect data on bugs and drugs, but also collect some clinical metadata so that the data become more valuable and you can interpret them better. Otherwise, practically, you mentioned the Fleming Fund already, and glass has been mentioned too. One of the requirements for glass is having a reference lab. In Vietnam, we are doing very well with support of the Fleming Fund of developing surveillance network. And the reference laboratories, one has been established, and they will hopefully soon be assigned formal reference laboratory status. And having that in place alongside a surveillance network, being able to send the specimens there for the confirmatory testing and figuring out whether there are new mechanisms is, I think, locally, to answer the question for Vietnam, is a key piece of progress that needs to be made.
That's helpful because I'm sure it holds true. So let me go to John on this one. What do you think, John?
I think that I agree fully that we need to develop an architecture that is not a reactive architecture, but rather a proactive architecture in this. I think I'm just wondering if with all the years thinking about AMR and with working with you all and others, how we have framed this, if we have framed this appropriately. And I think maybe that we may come out of this crisis saying, well, we need to step back a little bit and frame issues of AMR in a most appropriate manner that will get the right attention. And on that, I really just wanted to say that as public health matters. I mean, Sally, you talked about this, you touched on this. I mean, where do we go from here with public health? It matters, but we have to put that in the current context that the world has evolved, and we've now seen the power of politics in public health. and make sure that we position public health and thrust it into the center of the political leadership all the time, so that the issues get traction. The only reason that COVID is getting much attention, of course, is that, yes, it's a deadly disease. 2, it's very disruptive. And 3, is getting a lot of political attention. So I think, what do we do to bring that political asset to bear in discussing the narrative around AMR? I think that is what I call good public health equals good economics. I think this is, clearly a case to be made for AMR as an economic case that will draw the attention of the political leadership, and that is underpinned by good public health practice.
Yep, absolutely. I think we're going to come back to framing, but here at the moment, Hanan, what we're discussing is how to join up local bits and what more is needed to get that immediate reaction that they need at the local level.
Thank you, Sally. A very important question, and I probably spent a majority of my previous career tackling this issue in my country and the region. And I think when we talk about surveillance, if we talk about antimicrobial resistance and use data, so let's not forget the use data. One of the challenges, well, first of all, we need the antimicrobial data to be, the susceptibility patterns to be available immediately for an immediate need, which is treating a specific patient. The next level is to having that data available in a fairly immediate way, which we usually say 3 months to 6 months of recent data, to create antibiograms for hospitals to start tracking trends. The use data and IPC data is important to look at interventions and how they're actually affecting these trends. And they also need to be somewhat relevant, not on a day-to-day basis, but relevant enough so that I can give feedback to the stakeholders on behavioral and practices. So the urgency of having the data somewhat live and relevant is extremely important to keep our finger on the pulse and to address the interventions that are happening. Then we move to a more national level, where the data should be relevant because and somewhat recent, is because not every hospital can do what I just described. So they have to look at national level. The least appropriate is having global guidance on trends of where certain resistant patterns exist to be aware. So I think again we go back to the basics that the relevance of this data is extremely important. GLASS truly does have a way of doing it, but it's not going to be relevant for guiding immediate policy or policy at hospital facility level, but can guide a little bit on where to go with AMR, and it's very helpful in that. But it's a very complex situation, and what makes it also complex is when we talk about the MDRO data, at the national level, they have to start by unifying the methods of surveillance. So how they're testing their susceptibility patterns and working with laboratories, those of us who have tried and attempted to do that within a country, to try to unify the methodology of collecting the data. I won't talk about usage data, that's even more complex, by the way, but the microbiology data is extremely complex to unify the laboratory methodologies and SOPs and whatnot. So it's really putting the champions on the ground. And one thing that I think is going to be very important is to help build that national capacity for the countries to own the process with the proper leadership. Over.
So I think we've brought in a couple of things. One is that it's not just lab data we need. We need to know what impact it has on patients, the disease burden. And one of my concerns as to why we haven't been able to get the attention we need is because it doesn't have a face. COVID has a face. It's on our televisions and our front pages of newspapers every day. How do we get a face for AMR as part of this push? It's not even on death certificates in general. I get people saying, oh, my auntie died of an infection. I said, oh, was it an untreatable infection? Well, I don't know. How would I know it was AMR? No, we just don't do it. What are we going to do to give this a face How can we use data or some other mechanism? Roger, what do you reckon?
It's an incredibly difficult question, Sally, and I know you've been asking it in the past as well. I still don't really have an answer to it. We need to keep stressing it. We need to present it as another. I do think we can leverage COVID-19 in our communication about AMR, using the word pandemic, which it truly is. I'll pass to the next.
Well, no, I'm going to pick up a question from one of the listeners. What are the gaps and spaces to address AMR in low middle-income countries? And importantly, how can they be filled? So, John, do you want to come in on that? The gaps and how are we going to fill them?
Yes, I think that's a very important question, and that you can look at it at different levels. The first is really awareness and community awareness. Have we created the right awareness that such that antibiotics are not given, as was mentioned earlier, as a sign of love to somebody, or actually as treatment? I really love that piece. I think awareness is really community awareness campaign is very important, and it should be sustained, not just devoting a day, calling the AMR day, and then everybody else forgets about that. I think without that level of awareness, it's just impossible to create that. Then, of course, the second thing that we need to is that access to drugs. I mean, you can't be talking about this and in a comprehensive, holistic manner if you don't have access to antibiotics in the resource limited setting. And when I say access to, I mean quality antibiotics, not just substandard antibiotics. I think we have to very deliberately begin to think of regional manufacturing of that, and regulatory systems that will make sure that the quality of antibiotics is ensured in the communities that we live. I think I don't have the data there, but we all know that it's a large number of antibiotics that are out there circulating that are substandard, and that is a real danger for everybody that in the developing countries.
Yeah. Yes, the data I've seen is that 50% of these counterfeit medicines are antibiotics, but I don't know how much are counterfeit. Hanan, we've got a question from someone. Can you describe glass? We've been talking about it, and we just need to describe it so everyone knows.
I wish I was able. Thank you, Sally. A great question and a complex one. I would like to guide them to our website, which it has the detailed description of it. But in a very brief summary, it's a platform where it allows countries to engage to enroll. And enrolling into GLASS doesn't mean that they're necessarily submitting their data to it about their pathogen resistant pathogen pattern for a specific organisms. And the way GLASS functions is that so they can enroll first, and then after that they are linked within their region and then within HQ to allow them to understand the platform and what do they need to be able to submit data. So we do not take any kind of data. It has to be worked with in a way where the quality of the data is ensured, and that there's a process to enhance national surveillance program. So it's not an easy system. It's quite elaborate, and there's several other, if I remember correctly, at least we're piloting 4 other platforms, including antimicrobial use, emergent pathogens, gonorrhea or multi-drug resistant STIs, and a few others. But I think the best thing is to refer them to the website.
I'm glad you were explaining it, because I have to say it's quite complex.
Yes, it is.
So it's a data collection tool for countries to put data into so that it can be shared and we can learn from it together, I think. So we're coming to an end of this rather interesting, well, I found it interesting, conversation. And as COVID plays out over the next year or two, are we going to be able to repurpose back to AMR? Are we going to be able to reframe it? So what I want to ask each of you to do very quickly is give me the one, I'm your fairy godmother. What's your one wish as we come to an end of this conversation that we want countries to do? So we'll start with you, Michael. Tell your fairy godmother.
Well, since the fact of the matter is the kind of pandemic we're seeing with COVID-19 right now comes quickly, the pandemic of antimicrobial resistance comes slowly. If you were my fairy godmother, you would help us, the world, understand post-COVID that the next big pandemic they need to plan for is both influenza and for AMR.
Good. That's a great start. So that's about public engagement and political engagement in order to move the system forwards. John, I'm your fairy godmother.
Would be to take the opportunity that COVID has offered to bring public health to the fore and strengthen our surveillance systems that will benefit AMR.
I like all of these. Well, both of them. Let's see if I like them all. Roger.
My wish would be for countries to prepare for pandemics rather than start fighting them when they have arrived, and to take coming pandemics as seriously as Vietnam has taken COVID-19, both government and population.
Hanan.
You make it difficult for the last person, but I think since you're a fairy godmother and you can do anything, is to instill the wisdom in the leaders to prioritize and sustain the prioritization of AMR and not having it fall off the bandwagon every time something else comes up, because it does kind of float up and down.
Yes. Gosh, how can I top all of that? So I want to thank all of you because I've learnt lots. But I think what we've discussed is how COVID has made visible the issues of having a pandemic. I used the metaphor of the lobster and the noise it makes, and has created an urgency. And what we've been sharing with each other and with all of you, and thank you for the questions, of which there have been a lot, is the need to get that urgency into the antimicrobial resistance arena, because it's happening now, and move antibiotics on from being love. I always thought of food as love, and now I'm adding antibiotics. I'm failing my kids. I never gave them antibiotics. And we've got to think through how to frame this better and to make sure that we get both our communities and our people involved. And so comms is very important, communications, but we've got to look at the political aspects. We can't walk around that. COVID has shown us how important political prioritization is and how much we need this in order to do things effectively in the future, in part because they prioritize the money and the capacity. We've seen labs repurposed. Can we, at the end of COVID, capture those labs and make sure they're delivering microbiology to support the health of people, which will mean diagnosing infections and antimicrobial resistance and responding effectively? It is essential across the world. But hand in hand with repurposing the labs, we know we've got to improve access so that all patients who need antibiotics wherever in the world can have access, not just to antibiotics, but to the appropriate antibiotic of high quality. And thank you, John, for bringing that in. We heard, and I think it's true across the world, but it's most difficult in low-income countries, how microbiology is underused. And that comes to the issues of funding of the health system, but also incentivization. You know, in our communities in Britain, we don't do as much diagnostics as we should, I believe, in our community health service. And it's because it costs a lot more. So we don't incentivize doing the right thing across the world always, and we need to. We've talked about antibiotics as global goods, so we need surveillance, and all of this needs good governance. And that was one of the core themes of the interagency coordination group. So we keep going on that. And we've talked about, as we reframe and keep this under the banner of health security, we shouldn't lose the opportunity of postmortems on COVID to make sure that we move forwards much better on AMR. We talked about value and air traffic control, what makes for good public health, and the need for data. But if I could do my own fairy godmother bit and ask someone else, I think we need more capacity out there at every level to do the work, to think about the data, to support. And that has to start with microbiologists and decent laboratories to work in. So my clock has just struck the hour. Thank you for joining us. What a wonderful meeting. I've learned a lot and enjoyed it. Thank you, everyone.